Right. Congratulations on surviving your first day at BritSpine, almost. It's a great pleasure that I'm happy to introduce Professor Peter O'Sullivan. Peter is a John Curtin Distinguished Professor at the School of Allied Health Sciences at Curtin University in WA and a specialist musculoskeletal physiotherapist. With his team, he has published over 350 journal articles and scientific papers. The work is mainly focused on person-centered care for people with disabling musculoskeletal conditions. Peter also works clinically with people with persistent musculoskeletal pain. Please help me give me a warm welcome to Peter O'Sullivan.
Thanks so much. It's always tricky to get the last gig of the day, so my job is to try and keep you entertained at least for a little while before you head off for a drink or some dinner. So I was asked to talk about communication in this session, and the plan is to talk about what kind of communication might not be helpful, and more importantly, what kind of communication is helpful when working with people with pain, and in this case, back pain. So I'm going to start the presentation with this story.
41 years old, married with 3 boys, come back at work full time, and yeah, I've got a few hobbies, lifting weights and boxing. I got it from doing weights, so it was self-inflicted. I had a discectomy between L5 and S1. I had a nerve sleeve injection. I was a week out of having a fusion. So yeah, I was pretty bad. I went for a second opinion, went to a physiologist, went to a physio, 2 other physios, sorry, and they all said, look, if the neurosurgeon, if he said you need a fusion, you need a fusion. And the neurosurgeon had told me that I'll never run again and stuff like this, just stuff that I didn't want to hear. From pretty early on, I started on quite a lot of drugs. I wasn't sleeping well. Having Lyrica, Tramadol, sometimes Valium and meloxicam and anti-inflammatory. All I was doing is laying around because I didn't know what else to do. I'm dealing with 3 kids and not being able to lift up my 2-year-old and my wife, like putting her through, because I'm not moving, I'm laying on the ground. That's all I'm doing. I'm getting up for 20 minutes at the most. And you know, I'm just in a real bad state.
So presumably most of you guys work with people with pain and come across stories like Jamie's all the time. People like Jamie who's had a whole bunch of care and they've had injection therapies and non-invasive therapies and had a discectomy, and then it's like, well, what are we out? We're out of options here. And so his last option was to have a fusion. So at this point, he's off work. He reports his pain to be severe. He's disabled, really disabled. He's not going out. He's not socializing. He's very distressed. He's frightened. He has this view that his back is damaged because of findings on an MRI scan. So he's frightened to move because every time he moves, he's thinking this is a sign that there's something damaged in his back and he's going to do more harm. He's lost hope. And his mood is really low because he's lost all the things in his life that he values, and it's putting pressure on his family. There's financial stress as well. And so what are his options? So he'd been given this MRI report, which doesn't sound that pleasant if you read it. Words like degeneration, disc bulges, annular fissures, facet joint arthropathy, and this message, he said, these words terrified him. This was a meaningless, a guy who valued his physical health, who was boxing and doing weight training, and he said, I need physical activity for my mental health. And he was just unraveled because he couldn't do any of these things. So Jamie, as he described it, had lots of treatment, but these treatments, if you think about them, were linked to messages. The way that back pain was communicated to him is to, strengthen your core, be careful with your back, watch yourself when you bend and lift, and make sure you stabilize your spine. And then more of that through his PTs. He'd had information around his imaging that was frightening for him. And this had been reinforced with the messages he'd been given through GPs and through the neurosurgeon. He was on a pile of drugs that really weren't doing anything for him, in that his levels of pain and disability were so high. So you think of the messages he'd been given as like, you need a scan, or there's no danger in a scan, but the communication that came from that was that your back is degenerated. You damaged it, and you need, if at rest, you should be backing off. That you need to protect this back of yours and start, sort your posture out, sit tall, use a lumbar roll, and be careful when you bend and lift, and don't run. In fact, minimize how much you lift, and brace your core when you move, because that'll stabilize your degenerate discs. And these messages, I can't run again, I can't lift weights again. And even that message was given to him, even with the view of having a fusion. No more manual work and the drugs. So he's like out of options, and the last option in his head was to have a fusion, which he really didn't want. So if you were in the earlier talk, we hear the story of people like Jamie. It's kind of sad, is that these experiences of healthcare around the communication reinforces that pain means I'm damaged. And that often leads people like Jamie to become distressed and disabled, and feeling invalidated. And then the psychosocial impact, he describes this, the impact around not being able to do things, not being able to work, not being able to engage with lift his 2-year-old, care for the family, and do things that he values. That pain became frightening, unpredictable, and threatening. This uncertainty is for this future, things I can't do anymore, or this loss of identity. And then coping with pain around pain hypervigilance and body hypervigilance and overprotection. And reliance on medications that just weren't working. And then the sense of social withdrawal, of losing social contact with work and with friends and family, and this juggling act of pushing through or acceptance leading to despair. So, there's no doubt that we've got a large group of people like Jamie in our society who with back pain. And the question is, how do we communicate with those people so that we don't harm them and we support them in their journey? So we look at the things that influence people's chronicity of pain, then their perceptions around their body, their understanding of their pain is really important. And if the perception is that you have a belief that your pain is caused by structures that are damaged, then of course it makes sense that you will protect it. That if that is your belief, it makes sense that if you feel pain when you move, it will become frightening. It makes sense that it will be distressing if it starts taking you away from the things in life that you value, and that will impact on your mood. And of course, that will drive certain behaviours. So it makes sense that if you have a belief your back is damaged, that you'll avoid things. You might avoid bending and lifting and twisting, and you will overprotect your back and guard yourself and care for your postures, because that makes sense if you think that you've got to protect these structures. Problem is, that's a cocktail for chronicity, and we know that from a lot of studies, that a negative mindset around pain and pain-related fear and distress and overprotection and avoidance leads to a pattern of pain and disability. And we know that clinicians play a key role in this process. So when we start thinking about not just how we communicate, but what we communicate, there's growing evidence of what can be helpful and what might be unhelpful around the way we care for people. So what about what we say? This was a study of a colleague of mine in Finland, Riikka Halopainen, and she took video consults of a consultation that was videoed and back to the patient and said, tell me what you thought about this consultation. And it unleashed this whole story around all of the interactions in healthcare. And they described, there are things that we really have found so unhelpful in our healthcare interactions. We find it unhelpful when we're not listened to and we're interrupted, when we're not validated or considered, or our concerns and expectations are not considered, or we feel blame for our problem, or we're given inconsistent or scary information. When things aren't written down, when we're hurried and rushed, when we're not followed up, or we're overtreated unnecessarily. We don't like this. This is the stuff we don't like. if we look at the beliefs that people with back pain had, and we did this, a part of our randomized control trial I presented earlier, we followed or interviewed about 80 people with chronic and disabling back pain, and we asked them, what do you think's going on? What do you think the cause of your pain is? And there were a whole bunch of things that came out. There was this belief that the back pain was a serious medical condition. There's a general view that this was persistent, this is for life, that there's no chance this is going to get better, this is just my lot. There was a belief that the cause of the pain was due to damage, and that was often reinforced by the way imaging findings have been communicated to them. This idea that the back is like a broken machine, and of course if it's broken, you've got to fix it, and of course if you fix it, if you don't fix it, you have to just live with this broken machine. There was a belief that you need scans to diagnose the cause of back pain. And of course, that's definitely the case for a small group of people. But for the majority of people with back pain, we know that those scans are not predictive of that person's level of pain and disability. There was a belief that painful movements and activities should be avoided, that it was a sign that you should back off, that you should listen to your pain. But that led people to becoming more and more disabled. So it wasn't a helpful strategy. There was a really strong belief that their pain was caused by a weak posture or poor posture or a weak core, and so they had to be vigilant around the way they used their body and guarded their body and tensed their body. There was a strong belief that these pain flares were a sign that these were episodes of more tissue damage, and so this idea that they were doing more and more damage to themselves when their pain flares occurred. And there was also a strong view that stronger drugs and surgery was really the only option for them to manage this problem, to fix the damage in their backs. And we often see this around the kind of the communication around the reports, for example, or the messages that we give people to, be careful when you bend and don't round your back when you lift, and, use your body like keep your body upright and squat to lift, and be careful when you sit. And we know there's no evidence that these things are a risk factor for back pain, ironically. So when we ask people, these patients, where did you get this information from? Invariably, it came from interactions with healthcare practitioners. It was invariably the case. And often patients didn't hold one view, they held multiple views. They had a variety of beliefs around their pain. This study was, this is not our work, but this was a really interesting study that took a group of patients with low back pain who had no signs of red flags and no indications for surgery. And they MRI'd all of them, and they randomized them to two groups. One group, they factually explained the scan, just like Jamie. You've got degenerate disc and fissures and arthrosis or tears in the fissure. And the other group, they just said, these are normal incidental findings. They then, all of them went through, they didn't control the treatments they had, they all went through conservative treatment, and they followed them up 6 weeks later to look at their levels of pain, self-efficacy, as well as their functional status and their mental health status. This is kind of interesting data, I reckon. So this is looking at pain scores. So the people who have been given the factual information, describing the detail in the report, their pain levels were up. Those who have been told that these were incidental findings significantly had reduced pain at 6 weeks. In terms of physical function, the same thing. So those people who have been told this is normal incidental findings, their function levels were up. The other group, their function was reduced. Same thing for pain self-efficacy, and the same thing in terms of mental health. Now, if there was ever evidence for the way we communicate a scan, this study is so strong in terms of demonstrating that the information we give people is so potent. It will impact their levels of pain and their disability and their mood and their levels of confidence and the way they function. So just that in itself tells us something about the way we need to communicate with people with pain. And then there's this really interesting work, and some of the about what patients interpret from the words, and some of this work was in the UK from a Barker study a number of years ago. But words like chronic interpret as a couple of steps from a wheelchair. So it may not be our intention, but the words we use can have huge potency around what is interpreted from them. Instability, liable to pop out, not much you can do. Wear and tear, something's rotting away. degeneration, old person spine, disintegrating. So these words have potency. So an MRI report that the patient may even access and start Googling could have these kinds of interpretations that can frighten people. So we start looking at the influence of language on management intentions. My colleague Mary O'Keefe published a really interesting paper that asked people with and without back pain about a certain of these different labels and whether it would influence their intentions around management. So the labels that she introduced these people were you've got a disc bulge, or you have degeneration of your spine, or you have arthritis of your spine. And if they've been given these labels, diagnostic labels, these people were more likely to perceive a need for imaging, surgery, or a second opinion. They were more likely to perceive that this is a serious condition. They had poorer recovery expectations, and they were less likely to engage in physical activity and work. Just the label. So that comes back to the way we perceive our pain or the perception around that. It's not just about what we say. So around what we say, this idea of promoting a negative mindset or an undue focus just on structure, when we know that structure doesn't predict a lot of the things that are important, that language that is threatening, or that the idea that pain is proportionate to damage, or that movement and activities that hurt should be avoided or backs need protecting, these are the kinds of messages that we give people that could leave them into trouble. And then, of course, it's how we say things. And this is just taken from Ian Cow's work, this idea around, he's done conversational analysis around consultations of physiotherapists with people with back pain, and captured the kind of clinician-focused communication where the focus is on signs and symptoms and ticking boxes rather than on the patient's agenda, their concerns and their emotional distress. And in this scenario, you see the patient says, I have trouble sleeping and it gets me really low. And the clinician says, and do you get any leg pain? Looking at the notes. So in this situation, the patient's highlighting that they're having trouble sleeping and it's getting them down. And the agenda of the clinician is not about, that sounds really tough for you. Can you tell me more about that? How's that impacting on your mood? It sounds tough that you're sleeping. Tell me more about that. It's like, yeah, what about your leg pain? And so the patient's concerns are ignored over the clinician's agenda. And we know patients don't like that. So what are the characteristics of clinician-centered communication? Often they're closed questions, ticking boxes, not listening or responding to the patient's cues, minimizing or ignoring the concerns, very generic reassurance, closing down the patient if they're stressed, interrupting them, using jargon or language that's scary or that they don't understand, and non-verbal cues, a lack of eye contact, looking at the computer screen, closed postures, leaning away. These are the things that make our patients feel uncomfortable. So what might the impact of this communication be? And there's a recent paper that just came out of JAMA looking at clinicians who don't demonstrate empathy, is that the impact of that was the patients reported more pain, more disability, poorer general health. They were more distressed. And this had greater impact than the interventions that were delivered. The communication was impactful on their clinical outcomes. So what about the other side of the coin? So this is the kind of dark side. What about the other side? So what kind of communication might be helpful for patients in terms of what we say? Well, the same study that Rika Halapainen did, the patients were saying, you know, these are the kinds of interactions we found really unhelpful, but let me tell you about the helpful ones, because we've had some really good ones, and I want to tell you about that. And this is what they said. We find it really helpful when you care and take the time to listen to our worries and concerns and fears. We find it helpful when you validate us, when you reassure us and you build our confidence, when you understand our goals and our life circumstances. We also find it helpful when you explain things to us using simple language. When you provide a plan that's flexible and adapted to our lives, when you provide resources for us, when you make us aware of our body, you put us in charge and you work as a coach and you help us modify our lifestyle. So that's a very different kind of scenario to what we heard on the other side, where they felt invalidated, dismissed, and frightened. Here we got a story of being listened to and their concerns are listened to and empowered to take ownership over their problem. So what might be a helpful approach to communication would be an evidence-based approach, that low back pain is very rarely a serious medical condition. Of course, when it is, you've got to screen for it and you've got to identify it. That most episodes of low back pain get better within a couple of weeks. That low back pain is very rarely linked to tissue damage, that a lot of back pain episodes are linked to minor events, not damage. And we know that findings on a scan are very poor predictors of future pain or levels of pain and disability, and once you've excluded serious pathology. So we know there are highly active athletes running around with disc degeneration and not bothered by it. So that scans are not needed for most people with low back pain because it doesn't change the management. That actually avoiding and overprotecting the back delays recovery. It actually takes stuff away from you. It makes you more disabled. That movement and activity promotes recovery. That back pain flares are more predicted by things like being sedentary and being sad than any load to the back, and they're not a sign of tissue damage. That caring for your whole health is important, engaging in physical activity and caring for your mental health, engaging in healthy nutrition and good sleep habits are important for your whole health. And that strong drugs are not that helpful in the majority of cases. And we heard the story about the opioid burden around a lot of people with back pain in our last session. And that surgery is usually not needed, and it's not the panacea for most people with back pain, and if you look at the long-term outcome data. So this message is evidence-based, but sadly, it's not that common. There was a recent paper that was published by a chap called Dave Nichols who kind of talked about the relationship, like heart disease. We used to think of a heart attack 50 years ago, of advising people to rest up and be careful and don't stress the heart. And he kind of highlighted that maybe we're looking at this whole story around back pain is a bit like what we were doing with heart attacks 50 years ago. It's actually hurting people and leaving them more vulnerable. And I think he's right. So what about the diagnostic label? So Mary's study just asked people about these other really non-threatening labels. You've got a back sprain, or you've got non-specific low back pain, which, is like, we don't know what's going on. Or you've had an episode of back pain. And interestingly, these labels were perceived as less threatening. And there was a sense that if they'd been given this label, these people had a less need for surgery or perception of the need for surgery or imaging or a second opinion. They were less perceived seriousness. The greater recovery expectations were more likely to engage in physical activity and work. So labelling looks like it's really important. So what might helpful communication be? Well, we know that there are a whole bunch of biopsychosocial factors that can influence the level of a person's pain and disability. We talked about that. These pain cognitions, these pain-related emotions and behaviours can set people up in a vicious cycle of pain and disability. So using language that is non-threatening, using language that promotes a positive mindset, that active self-management can be an effective way to deal with your pain, that putting patients in the driver's seat, that they're the best person to care for their own health, this focus on whole health, and that this idea of we work with them in a collaborative way. So what kind of messages might that give is that backs are actually really strong. They're strong to load. As long as you gradually load them up, then it's capable of bending and loading. And in actual fact, if you look at the studies around disc health, that people who run long distances have much stronger discs than people who don't run at all. That loading discs makes them strong, like bones. That pain is not an accurate measure in the majority of cases. Once you've excluded serious pathology, it's not an accurate measure of tissue damage. So we need to make sure that message is clear to patients that disc degeneration is a really normal finding in people without pain, and it doesn't predict how you feel in a lot of times. That engaging with movement, even if they're painful or frightening or avoided, actually, and building safety and confidence is a pathway to reaching your goals and getting back to living again. And caring for your whole health. That might involve your physical health, your work, your social engagement, your sleep, your diet, your mental health. These are all really important targets in terms of the way we care for people with pain. And what about the way we say it, or how we say it? Well, part of Ian's study also captured other interactions in healthcare around person-centered communication, which is a collaboration between the clinician and the patient, where the focus is on the patient's needs and preferences and values and their agenda. And in this picture, you see the scenario, I've got trouble sleeping, it gets me a bit low, and the clinician responds, that sounds really tough, can you tell me more about that? And the clinician looks at the patient in the eyes and engages with them. So in this case, the patient's agenda is the focus of the consultation. So what does person-centered communication looks like? It means we have time to listen to the patient and go, tell me your story, to show empathy and kindness and care, to validate their experience and them as a person, to respond to their concerns, to check in with them and summarize that we've heard it right, we've heard their story right, to reinforce positive behaviors. They want to engage in physical activity. That's so cool. You know, Jamie wanted to get back to lifting weights and running, and he'd been told not to. They were the things he wanted. But we want to avoid confronting people and arguing with them. We want to explore their goals and their values and their expectations and provide them with cognitive reassurance specific to their concerns. And we want to make sure that we have decision-making around their care that is shared. So what about the non-verbals? Because that's also part of it, is around the way we engage with people. And, you know, this shift towards using AI where we can fully engage with the patient, I think is really cool. That we're not sitting there typing into a computer. That we use affirming touch, and we can demonstrate, and we can use written and digital feedback as a useful forms of communication. And we know this builds relationships, increases disclosure of important information, it builds trust, and patients like it. So why is person-centered communication important? Well, this study in the JAMA showed it reduces the person's levels of pain and disability and distress. It influences outcome. It builds trust and alliance and collaboration. People are more likely to engage in the interventions if they trust you and they feel listened to. It facilitates disclosure, and it protects us as clinicians. It protects us from burnout, and it means we're less likely to be litigated against because patients don't sue people they like. And of course, it goes beyond the talking. It goes right through the examination, the way we manage them, and the planning. Patients like it, and they want it. Problem is, it's often not that common, and so communication needs training. And it's almost like a default that we go, well, that's a soft skill. It's not. It's a critical skill. It's a skill that every clinician who works with a person in pain who are distressed should have. And we all know that the clinicians who possess these skills are usually the very, very busy clinicians because they are the patients, they are the clinicians that people send people to. So, but communication skills are no different than technical skills. They require knowledge, mentoring and practice and feedback and repetition. So in the previous session, we talked about the Restore trial. I just want to really quickly go over this for anyone who wasn't in that session. So this used the person-centered approach, which was around empowering the person, where a strong therapeutic alliance was built. The patients were validated. And around this intervention was this process of helping people make sense of their pain. It was like, in the absence of being able to tell people a specific diagnosis, it's to go, hey, there's all these factors you're telling me that are interacting that we know can influence the sensitivity of your spinal structures. And those things you have control over. And then the second phase was building confidence in the body to say, you know what? You might have a degenerate disc, but the health of that spine, needs movement. It needs movement and loading and activity, and it needs you to get good sleep, and it needs you to care for your whole health, that it's safe to bend and load your back, even if you have these changes on your spine. And then targeting your whole health around other lifestyle-related factors. So this took training. It took time to train clinicians around this, and usually it's to teach people to communicate differently and to act differently in the way that they cared for their patients. And just very briefly, if you weren't at that session, this was published in The Lancet, this trial. It included 500 people with disabling low back pain. There were 3 arms, this person-centered approach versus usual care, the person-centered approach plus biofeedback, movement biofeedback, compared to usual care. 18 clinicians were trained, and the outcome measures were pain-related disability, which I'll just talk to here, pain intensity, and then economic analysis. So we saw sustained and large reductions in pain-related disability and pain intensity in the person-centered arms, with large cost savings of over 5,000 Australian dollars per person. So the $5,000 for one person more than paid for the training of that clinician. Just one clinician was paid for by the cost savings. It was safe, so there were no adverse events, telling people like Jamie that it was safe not to protect his back, to engage with movement, to get back to doing the stuff he loves, get back to boxing, back to your weightlifting. But it was a journey that took about 3 months. There was no added benefit to the biofeedback. So what did Jamie say about this? And Jamie sent me this video 2 years later, and this wasn't like an exercise program he was given by his physio. This was what he went back to. Now, it's kind of cool because this is a guy with very high levels of self-efficacy. He has no fear. He's like doing these random movements, loading, jumping, bending, lifting, twisting his back because it's good for him. And he tells a story here. Whoops. That should be on. Could you guys make that video work?
A week out of having that fusion, I found a physio. He was the last resort, and I was hoping that he'll say, you need a fusion, because I just want it all to stop. And then when he told me that he reckons he could help me, that was pretty full on. He said, you've got this degeneration, but so is most of the population. I told him, I said, look, I'm doing everything right. I'm putting the roll behind my back when I'm driving. And he said, what for? And I said, well, because everyone says to do that, And he said, throw it away. Like, chill out, relax, lean back, And he said to me, another important thing was he got me to bend over and pick something off the ground. And I was like, like this, guarding and protecting my back. And he said, you don't need a fusion. You've given yourself a fusion. So he gave us stretches to do, and to ride an exercise bike as well. And I was thinking, what? I can't do that. I've been laying down all day. I can't ride a bike. You think, why is my mind working against me? But it's just how I trained it to work for that 6 months or so. I'd work myself into that. And I had to get out of it, and it was stretching, and people are probably going to see this, and if I say meditation, they'll start rolling their eyes or something. But I did meditation. I went and I saw a psychologist as well, and that all helped me as well. Don't go onto the internet and read forums, because I think that people compete on there for who's got the worst, who's been chopped the most, or who's had the worst. It's just a nightmare. I went to a doctor, and she said, she saw me move, and she said, that's good to see you're guarding your back. I'm like, now I know, so you hear that and you think, okay, I should be stiffening up and that. What I know now is that everything I was doing was counterproductive to my recovery, big time. If I had known not to sit up apparently correctly, just to relax, chill out, you know. Throw the towel away from behind my back that was putting me into an unnatural position. Not worry about sneezing or coughing. The neurosurgeon said I would never run again. You know, I'm doing everything. Weights, I'm back doing weights again, and I go to boxing on the weekends as well. And to think that I'd kind of driven my mind, and to hear that, you know, it's a lot to do with your mind. I think some people aren't really open to that. They'll take offence to that and think, oh, you think it's all in my head. Overcoming that it had a lot to do with meditation, had a lot to do with me finding other interests, because I wasn't living. I was just existing, and badly as well. It was a real bad existence. And now I can do everything. I throw my kids around, you know, back hanging out with friends, going to work, which going back to work was really important. That helped me heaps. Yeah, just living.
Just living. So what kind of message was Jamie given? That your back's strong and that movement and loading is safe. We're going to build it up slowly, and you know, you don't have a perfect looking spine, but lots of people don't. And actually to make that spine healthy, you need to use it and engage with it and get your life back. And then, of course, that starts to promote a positive mindset. Those structures are super sensitive, for sure. Your muscles are clenched, but learn to relax them and get moving. Build that up slowly, that you strained your back, but it's not damaged. And we need to get you back to living. And that recovery is possible. And that actually relaxing and moving and engaging in activity and getting good sleep and getting off those drugs and socializing and back to work, they're all really good things for your whole health. And that builds confidence. You know, you can see him doing his crazy exercise routine, not a frightened guy anymore, with a positive mindset and back living again. So Jamie said during his journey with the clinician, he was listened to and validated as a person. I was given confidence back in my body. I understood that pain didn't mean I was damaged, that I understood I was not defined by my MRI scan. I learned that from my flare-ups, and I got my life back. What did that look like? Person-centered care, building confidence back in the body, back to the gym, back to his goals, back to work, socializing with the family, got off the drugs, didn't have a fusion. 5 years later, still hasn't, still living. So unified communication and goals across the whole health team. So the GP and the psychologist and the physiotherapist work with Jamie to support his goals and his agenda and take him back to the things he loved, and with a great outcome. So after 3 months of care, not a lot of sessions, he was taught to self-manage his situation with a positive mindset, minimal pain, not pain-free, but not controlling him, getting active, building confidence, getting engaged, becoming fearless, hopeful, and happy. So why aren't we delivering these messages to people with back pain? This is the thing that really gets me as a clinician, as a researcher, because the evidence is overwhelming that we are hurting people with the way we communicate with them in our society. Just seems crazy. And there's so much evidence around iatrogenic harm that we're doing to people like Jamie. So clearly this is part of our identity as clinicians, the way we're trained, and we may not value training around communication, but it is so important and we can't avoid it. It will enhance the therapies that we deliver people, and we all want that. In terms of patients, you know, some of these messages are countercultural because we know there's a discourse and community around back pain. Like everyone knows if you've got a bad back, it's going to end up with A, B, C, and D. We know that these are messages that are pervasive right through. And so we've got a public health job, just like heart attacks 50 years ago, to change the narrative around back pain. That it's not something you should protect and guard and avoid and stop doing and start lifting awkwardly and sit weirdly. And then we need to make sure that we have time for people in our health systems, because if we don't provide time, we're just going to create that circle of revolving door of people coming back and back distressed. Because they don't feel validated and they have no answers and they're stuck in their life. And of course we need unified communication so that we're not talking different languages, and the physiotherapist and the GP and the surgeons are all, and the pain physicians are all speaking the same language, because that's where so much of the confusion happens with patients. They don't know who to believe and they don't know who to trust. And, you know, we're probably at the bottom of the food chain and, as physiotherapists, in terms of the weight of the things that we say. And then, of course, you know, we've got a kind of culture that's looking for quick fixes, and with chronic pain, quick fixes just don't exist. We know they don't exist, so we can't promise them. It's a journey, and that journey can be really tough for some patients, and we've got to make sure that they're alert to that. But I think there are so many opportunities. We have opportunities to educate the public around pain, just like we have done for educating around heart attacks. We have an opportunity to upskill clinicians and embed communication training and the what and how we communicate to people at the very beginning of their journey through basic education. And then we have an opportunity to have, you know, meetings like this where we've got cross disciplines that we can share common messages so that we support people through their journey. If you're interested in this work, then there's a website there that you can track down some of the work that we've got. We've got patient stories that are up there, infographics that are co-designed with patients that they, and their language that they want, the kind of language they wish they had been told, the kinds of things they wish they had been told in their journey as well. Thanks very much. Just to acknowledge the people that I work with, you know, both here in the UK and other parts of the world and back in Australia who are part of this work. Thanks so much.
Thank you, Peter. A great talk. Are there any questions? I think there are some mics at the front.
Awkward silence.
No. Cool. I have one, Peter. So I think we've kind of, you touched on it, that it's kind of the workforce and how can we kind of start thinking of training people differently, especially kind of across our disciplines.
Well, I think it's, I don't know about the UK, I can only speak for Australia, but I had a GP as a patient a week ago, and she said, how come GPs don't know this? Like, why? I was never taught that. She teaches GPs and she teaches first-year medical students. She's going, why does no one know this stuff? It's all published in the medical literature. Why does no one know it? And she's going, I've used the backfacts, or back to basics. It was a backfacts paper that we published in BJSM. She's going, I gave it to all my first-year students. That's what has to happen. We've got to embed it early in training programs so that GPs, young training doctors and young physios, the physios hold with these beliefs as well. It's not like we're all part of this. It's the whole system. But we've got to educate people on what we say, but also how we say it. It's both. Because probably the most dangerous to be empathetic, telling people bad stuff, because that will probably stick. So we've got to have both sides of the coin, and that's something we should be all investing in, I reckon.
Thank you for the very nice talk. My name is Gagan Sethi. I'm from Newport, Gwent. My question basically is, patients, they come, they have already read their radiology report a lot of times.
Yeah.
Should we ask our radiology colleagues to word it differently?
Yes.
So that they don't get it where, in a way like damaged and arthropathy and breast bulges, and they're not relevant actually.
It's crazy. So, look, I 100% agree with you, but, we've talked to our radiology colleagues and they're like, they're frightened of being sued. So there was a really interesting study published in the States, actually, that gave the information, still gave all the information, and then put a little point to say, look, many of these findings are normal in the pain-free population, so they may not be relevant for your condition. So they still gave the information, but they put a little proviso next to it. And so consult with your physician or your care provider to help you interpret that. And actually, the result of that study, where they randomised it to either just the factual information without that proviso, that those patients were less likely to end up with opioid prescriptions. Now, whether that influenced the physician, it might have been that maybe the healthcare physician was more reassured than the patient. But it's a no-brainer. Like, I had a brain scan a few years back, and it said normal age-related changes. Well, I was like, oh, I was thinking I'd be better than that, but it didn't tell me all the stuff on it, and that was massively reassuring for me. That there was nothing. They probably saw something I didn't want to know, but it was okay. It's all I needed to know. We should be doing it.
Great. You've kind of answered Donald on you've retired spinal surgeon. I still do a healthy medical legal practice, and you more or less answered my question observation. We've known this stuff since the 1980s.
Yeah. Why?
Why in 2020? My impression, having observed the clinical community's interactions with patients over the last 45 years, is that it's getting worse, not better.
Yeah.
People are coming in more damaged, and it's more difficult to shift their beliefs. And an awful lot of medical behaviour is reducing the risk for themselves by over-investigating, over-advising, giving more information than is strictly necessary, unqualified. Now, we had an interesting phenomenon to the shame of the medical profession, I think, that it took politicians to legislate for deep vein thrombosis prophylaxis. I'm sure many of us will remember that 15, 20 years ago. The Australian government did something a little bit like that with legislating RSI out of being a major national disability. Is it time, do you think, for politicians to mandate the medical profession, the clinical community, to completely alter our interactions with our clients?
Wouldn't that be great? But I doubt it would happen, because it'd be an hour. The problem is, it's like there's a perception that all you're trying to do is save money, and I'm not getting the best care. It's so complex, isn't it? Because if the general discourse in the community is that you got back pain, it means there's something damaged. The only way you can identify it is through a scan, so you go for a scan. And if your healthcare provider is going, no, it's not indicated, then you feel like you're being deprived of the care you need, and that's probably because governments are trying to save money. So it's a really vicious, it's a wicked problem. But I think, as healthcare practitioners, we have to be courageous in the way we work with people, so that we just go, actually, this could be harmful. It's not benign, it's just harmful. And you're right, like, we have known this stuff. Like, what does it take? And maybe it takes a conference like this and a community of people to go, this is crazy, we have to change it. If it comes from within, it's likely to happen. Or if it's from politicians, it's likely to create a wild storm, I'd say. So thank you. I 100% agree with you. Well, don't quite retire yet, because it sounds like you've got a job to do.
Final question.
Hi, my name is John, and I have done a fusion for back pain. That's my confession.
Is that why you're moving so stiff? Did you do it on yourself?
Maybe I need no, fantastic talk. And as a surgeon, it was a great reset. We're surgeons, but we spend half our lives in clinic. So that was really useful refresher.
Thank you.
Pose two things to you, though. I scan everyone I see with back pain. MRI gets a bad press, and I think it's resource-based. But if someone's distressed with back pain and you can get them a scan and interpret it correctly,
but that's my point.
That can help them.
I'm not doubting that.
So I think we should cease on the bashing MRI scans. It's all the
I think you misinterpret me, because I'm not bashing the scan.
No, I was going to go.
Okay.
Absolutely.
Yeah.
I think the spinal community is quite anti-scan.
Right.
Generally, but it's what we do with.
It's the communication of the scan.
Yeah. And the second problem we face all the time is, what do you do if you see someone once and they react really badly to your communication about their pain?
Yeah.
Because we get
refer them to someone who will communicate better.
Just send them out the door.
Sorry, that was a bit rough. But no, like, go and talk to Tama Pincus about doing some communication training, because she's amazing. But like, I think it's so great that you come up and share that, because like, my clinical journey has been a journey of being told. I grew up in New Zealand, and the Mackenzie thing, I don't know if you know, Robert Mackenzie was a big deal out there. I used to give graphic details of people doing repeated bending and how the nucleus is going to pop out the back. I must have terrified so many New Zealanders in my early days. And that was my training. It's what I did. It's what I believed. And I think fundamentally there's this element of, we need to question our own beliefs around the body, right? That's number one. But also communication is a really important skill that protects us, and it makes our job better. It makes our patients happy. We hate it when patients are pissed off with us. And they're not hard skills to learn, but they do take time, and they're things that should be embedded in every clinician working with a human being, I think. And part of it, the work we've done is we film consultations and we go back and watch them with the clinician, and they're like, oh my God, I had no idea I said that. Because sometimes we don't know how we communicate, or we don't see it because we're in the moment, and it's not until we have that possibility of self-reflection that we can go, okay, how would I do that differently, and role play it and then try it again. And everyone's a winner with good communication. We're the winners. Our patients are the winners. The life's a better place.
Great. Thank you so much, Peter. And there's some refreshments and a great hall.